Good afternoon, everybody, and welcome to Zahn Academy. I'm Fran, Zahn Education's manager, and today I have Amir Basic with me, and he is an MDT, and he prepared this great presentation for you, Digital Transformation Journey of Implant Dentistry. Today, we have an interactive webinar, and we'd love you to please answer some poll questions that we've had put together for you so that Amir can know a little bit about who's listening on the other end. We'll also have a live Q&A, and that live Q&A will happen at the end of the presentation. There's a little icon at the bottom of your screen that says Q&A, and you can click on that and type your question in, and Amir will answer that live. So I want everybody to enjoy this presentation. Amir, thank you so much for joining us today and preparing this presentation. I'm going to turn this over to you.
Fran, thank you so much for the invitation. It's such pleasure to be again with the Zahn Academy. Last time, I believe we just did it shortly after COVID, where we doing a lot of Zoom meetings.
Yes.
So, and we kind of continuing this trend, especially in this very busy time where we are closing the year and everybody's pushing that last couple of weeks before everybody goes into the well-deserved holiday break. So for today, I have prepared a presentation just out of my experience working in implant dentistry. And I wanted to share with the community what would be the possible and how we can work more efficiently through the workflows. So I usually start my presentation a little bit with the feedback on the industry, where we're standing with our factors and our datas and our parameters. For example, currently right now in the United States, we are facing two challenges overall in the dentistry. One is the increased number of dental disorders. And the second one is aging population. By 2030, we're gonna have more people that they are 65 years and older, and they were outnumbered the people that they are 18 years and younger. So definitely it is a demographic shift in the United States that's occurring. So for some reason, my screen has been very shortly frozen, so I was able to unfreeze it. So the second data is directly related to CDC, Center for Disease and Control data. So based on their informations, we have a 26% of adults who suffer tooth decay. So this is an increased number in comparison to the past. And also 46% of adults, they have a certain level of perio disease, with the 9% having very severe perio disease in the process of losing teeth. So 36 million people are edentulous, and 150 million people are partially edentulous, meaning missing minimum one or multiple teeth. So if we take in that perspective, and we translate that into the numbers, so the dental implant market in the United States currently right now, it's by 1.65 billion. And we are expecting a double-digit growth over the period of the next 4 to 6 years. So if we traject to 2030, so we will be close to $3 billion in the total value of the market share. So that's very nice and exponential growth for all of us who are involved in providing care to patients. So during this history of implant dentistry, I have been already involved overall in dentistry for past 30 years. And we have seen the whole evolution. We are now in a stage, or we have entered already the stage of immediate placement. So today I will discuss two concepts of immediate placements. One would be the single units and the way we can prepare these cases, execute these cases, and also to the certain segment full arch cases and options that we have with full arch case implementation of the technology and the new materials. So the foundation for the immediate placement is definitely, again, research. So one of the great book that has been recently published several years ago was written by Dr. Dennis Tarner and Stephen Chu, two fantastic clinicians, fantastic and great educators. So, and this is some of the data that I have gathered just particularly out of this book, which was very interesting for me. So when I was observing the previous processes and the new processes, the way we do implant dentistry, and based on this data, so if the doctor extracts the tooth, performs some level of the bone grafting, and then places the implants in a delayed fashion, the survival rate on this implant is going to be 90%. So if he does immediate extraction, immediate placement, 95%. And if he does that in anterior segment, meaning extracting anterior teeth, placing the implant, there is a 97% success rate into it. So this is a kind of like a foundation why we have dentists, implantologists, overall restorative doctors, and the dental laboratories enter this segment in a very, very fast paced. So what this allows us is fewer patient appointments, increased patient comfort, and most definitely preserving the tooth, the bone and the tissue structure. So I will share with you a couple of the cases, the way we have prepared them and the way we have executed them, and the reason why we have selected certain techniques to do them. So for our anterior segments, so we prefer to use always a static guide. This case has been done by a periodontist in combination with a restorative doctor. So the implants is placed with a static guide. Immediate temporary restoration has been created in advance with the engaging parts based off titanium interface. And as you can see on the right side, this is immediate extraction, immediate placement. So this temporary has been secured with flowable composites just to prevent the microbe movement. And then on the right side, you can see the final crown in a place. What is very obvious is this papilla preservations that we see, and also the volume and the quality of the tissue that was preserved through this process. So this was our predominantly initial process, the way we have loaded the cases in anterior segment. And one major concern was patient compliance with their dietary habits, and also unconscious clenching and grinding and not wearing the protection during the evening. So we have involved into a little bit more conservative process. This is one case that is currently right now standard of care, the way I prepare and with my team cases for many of our perio and oral surgery and perio-pros clinics and overall implantologists. So on the left side is the case before we start with the failing tooth number 8. We prepare for the surgery in this more conservative way, a custom healing abutment, again, the static guide, and the ASICS appliance. So tooth is atraumatically extracted. Again, static guide has been positioned in a place, and implant has been placed in combination with the bone grafting. So pretty much this custom healing abutment, it works like a tissue plunger. So it preserves all the grafting that has occurred inside the sulcus, at the same time keeps nice shape and form of the tissue during the healing. At the same time, the ASICS appliance has been delivered into the patient's mouth during the healing process. That the ASICS appliance has approximately 1 millimeter clearance off, so there is no functional load on that implants during the healing process. This also allows patient to have a nice hygiene and easily accessibility for cleaning process during the healing stage and final tissue forming stage. This is 4 months, 5 months down the road, once the final crown has been restored. As it very obvious from this picture as well, the volume of tissue has been preserved horizontally and vertically as well. So as I mentioned, this is definitely our preferred way and standard of care to restore aesthetic zone, single implant or multi-implant cases with immediate loading protocols. Also, sometimes we have challenging cases where patients have an extremely high smile line, and preserving papillas are also very important. This is another technique. This is a little bit different surgically. It's with the partial extraction technique, PET technique. So where part of the tooth has been preserved in combination with the bone grafting. Again, custom healing abutment has been inserted, Essex appliance has been generated. This is the picture after the tissue and everything was formed. This is a custom made impression coping on the day of the first restorative appointment. And this is a final crown in a place. So again, very conservative, very successful, very predictable process, with the fantastic, I would say even world-class results when it comes to the tissue. Which is important here to mention, I will just summarize it, the use of the surgical guide, because in this anterior segment, once you have the extractions, the sockets are huge. And if you do not have the guide in a place, you can easily oscillate or slide into the socket, and that can cause some damages, and it will definitely affect the final outcome. So I recommend for every implantologist for aesthetic zone with immediate loading in a tooth process, always to use a static guide and never freehand. So when we come into the final restorative stage for the posterior area, so we do use prefabricated and some customized option as well. One of the company that I have with my team find big liking for is a desk company. It's a Spanish manufacturing company that manufactures generic parts. We use almost all my clients who do not use authentic parts use their intraoral scanners, scan bodies, and we use them also in-house for our own scanning. And also they have their tie bases, so which they are engaging and non-engaging as well. They have a pre-manufactured or blanks and abutments that could be inserted into the mill and could be mailed to customized option. Also, their analogs come in two options. One option is with a slide in, and the second option is the ones that you secure with the screw. Like I mentioned, I'm really amazed by the quality of their products, and we use them for many indications. So for our immediate temporizations, we will use the tie bases. For the final solutions, if we do not outsource it to preferred milling centers, then we definitely have options to mill with their titanium blanks. So the good thing about their titanium blanks, they have recently launched also angulated options, so which is another great product. So it just kind of a little bit increases the inventory because you have a different rotations, but it pretty much closes the loop in a customized production of the single units. So stock abutments, like I mentioned, originally we have restored the crowns, but over the years we have seen increased number of the failures. And the major reason for these failures was the height of the tie base. Majority of the companies have designed these tie bases around 4 mm, and also they have designed them with the angulated option. And every time when they design them with the angulated option, one side gets opened so that you can put the angulated screw into the chamber, which doesn't have too much bonding surface to zirconium. And as you can see on your right side, it comes very often to fracture, especially on the angulated screw options with the tie bases. Another challenge is this prefabricated parts. The first, second generations, they had very low gingival heights. Our clinicians, with majority of the systems, they prefer to submerge subcrestal implants, which has caused a lot of issues with the final deliveries, in which the tie bases, as you can see on the left picture, they will very often be sitting or hitting the bone and preventing from restoration to be fully seated into the place. And sometimes, even with your radiographs, it's very difficult to see and check that the screw retain implant crown has been fully seated in a place. So For that reason, in our operation, we have drifted almost 100% in a final restorations to be restored with the custom abutments. So we predominantly outsource our custom abutments to the milling center. One of the milling center that we use, if it's not authentic parts that we send to the authentic milling centers, we use a Creo, and they do a really amazing job with their abutments, their cement gaps, their seating surfaces and tolerances have been exceptional. I can highly recommend them for all people who do not consider to mill in-house abutments or have abutments they do not have a request to be authentically milled, to try some of this Creo milled custom abutments. So when it comes to the prefabricated abutments, I worked on a manufacturing site for 7 years. And during this time, I have done the validation on in-house milling of the abutments, predominantly in a mind to see if it's possible to do a repetitive milling of custom abutments with the consistent results. And this has been done on University of Washington in 2012, I believe 2013. And they came with really amazing results. And this test has been completed on a VHF mills. So, and the one reason why we had such amazing success with the N4 mill, which is a 4-axis mill, is that pretty much all VHF mills are built very robust. So they have a aluminum cast, they're extremely stable. Their spindles, they have not only speed, they have exceptional torque, which allows us to repetitively successfully mill high quality products. So, and as you can see, I'm gonna just play a short video. So this is pretty much after the milling, and once you're assembling these crowns, they fit like a glove to each other. So as you can see in the short video, if you just drop it, they just perfectly fit. And this is extremely important for the laboratory because we are in a little bit time crunch sometimes with the production. And we prefer not to make abutments, reskin abutments. So we do such called a split file concept. And if you are doing split file concept in your operation, what you prefer is that outputs that you get from your softwares or your designs actually translate into your physical objects, that they are milled on a high quality mills like VHF. And we have achieved that. So I get tremendous results on my zirconia fits, and also I get the same thing on titanium, which speeds up the whole process and gives that nice and intimate fit. So we don't have cement leakage or debonding issues because the cement gap is way too big in a marginal area of our final screw routine restorations. So another important segment that we have observed in laboratory is the diligence of cementation and the way we bond our custom abutments to our zirconium. Zirconium, as everybody knows, doesn't have a glass phase. It is a highly dense material, and it's extremely difficult to cement or bond. So we follow the protocol from Dr. Blutz from University of Pennsylvania. So his recommendation is sandblasting with the 15 microns with 1.5 to 2 bars with a 2-3 millimeter distance. So we are using a Remford sandblaster. I have been using reference products for decades. They are Cobra sandblasting particles. They have equal size, which increase the longevities of the nozzle and increase the longevity of the sandblasting machine, and as well reduces the consumption of aluminum oxide, which is also very highly toxic. So you want to go very efficiently, create the perform sandblasting, create the micro attachments that mechanical retention into it, and then go to the next step. This is another product that I have introduced into our production after I got tip from good friend from Germany. It's a cold plasma, cold atmospheric pressure cleaning. So what we do pretty much for all our zirconium work, doesn't matter if we bond or if we layer ceramics or glaze it on it. So we just run it with this plasma blasting machine. And what this does is it cleans the surface and removes anything that's organic or inorganic, any dust particles, they get blasted away. So, and it tremendously reduces the surface tension and increases the wetness. So if you are glazing your zirconium crowns, you can really nicely clean the surfaces and pretty much achieve the one glaze bakes with the great results. Same thing with the cementation. So the cement really nicely spreads through the inside or the intaglio portion of the crown. So in this way, we can get very uniform cementation, not only on the single units, but also on a big cases, specifically ones the bar supported zirconium bridges. So definitely recommend to take a look into it. The product is called Rely On Plasma, and they have a couple US distributors that you can purchase this product from. And it's not that expensive, I think a couple $1,000 range. So part of our cementation protocol is also using primers or cements. They have a primers built in. Extremely important is to have a phosphate ester zirconia primer built into your cement that you're using. And if you don't, then you have to have additional liquid that you apply, you correctly dry it, and then you go through the process of the bonding. So for the years, we have been using Bisco Terra generation. Now it's Terra Sem. Very successful. We have reduced through our technique of proper sandblasting, proper cleaning, proper bonding application and cementation, and the light curing, which is extremely important. We have reduced our debonding to really minimum, bare minimum. So also important with the zirconia, any zirconia that touches the surface of the tissue, we highly polish that surface. And all study indicate to us for highly polished zirconia, if it's highly polished, it's going to be antimicrobial, and it will prevent development of biofilm. It will reduce irritations, and it will be more tissue loving. So that's another protocol that we have implemented besides polishing the titanium interfaces, custom abutment intaglio surfaces. We also polish the zirconia, and the feedback of our clients, as you can see on here on the right side, is a highly polished surface. It has been fantastic. So, and they also recommend now their hygienists really do not go deep and clean around the implants. If the tissue nicely adheres, if the tissue looks very healthy, there's really no reason to poke it and disturb it. That nice biological healing process. So I want to also share with you this. So this is another product that we have find to be excellent. It's a Horico. It's a product from Germany, or a company from Germany. They have a two line. They have Horico. They have Sunshine line. It's pretty much the same company, same quality of the products. So one product is a rotary product. It is a heatless stone. So anytime if you need to do any adjustments on zirconia, doesn't matter if it's contact points or you have missed something in a design and you need to slightly reshape it, this is a fantastic stone that cuts, doesn't create the heat, reduces the micro cracking. At the same time, it allows very easily polishing sequence after that. So, and recently, a couple of years ago, they have also launched this like silicone, diamond impregnated silicones, lamellas. So if you are looking to create nice polish in your interproximal area, or you're looking to do some additional polish on your zirconium crowns after the glazing for some surface effects, this is a great tools. Yeah. And for all our adjustment in a marginal area and all our finish, we use predominantly high speeds, and they have a fantastic burst. So tip for today, definitely, if you're looking to work with zirconia, their products are world class. So now when it goes to the posterior area, we have spoken in the first segment of this presentation on a single unit, immediate loading and aesthetic zone, and what would be the protocols. Now we see more and more immediate loading, not immediate loading, sorry, immediate placement in the posterior area. So the whole new generations of implants, they are available in the market. Every major player has come up with a more aggressive implant and with the conical connection. One product that we are really excited and to work with is a product called Smart Shape Healers from BioHorizon company. BioHorizon is also part of the Henry Schein umbrella. So it's a fantastic, fantastic company. So we have restored a lot of BioHorizon cases over the last 20 years. And myself and our team has worked also with a team who has developed the concept of Teeth Express. So some of our initial first cases that we have done have been used for now 2 decades for the marketing activities of BioHorizon. So we have a great experience working with their system. And I was very glad now to see that they have combined their conical connection into their product line. And also they have launched this Smart Shape Healers, which allows the clinicians on the day of the surgery or in a second stage to really position healing abutment that has a anatomical shape. And what that anatomical shape provides us, it is a perfect emergence profile. And once we have this perfect emergence profile, it simplifies the digital workflow and it allows us to really create anatomical crowns. And if I can say, they look now more like a teeth. So it is definitely product to look out. They have recently launched this. So it comes in a different gingival heights. So for the people who are using screw end connection, they are still slightly placing the implants above. So they're using the shorter or lower version. And then for people who are using Conilog now connection with the Taper Pro line, so they are going to be using predominantly the Smart Shape Healers with the taller heights. And as you can see, these dots, they indicating the connection size, and the lines, they indicating if it's lower or the deeper gingival heights of the Smart Shape Healers. So this is totally not related to the scanning. The scanning, it's predominantly done with the surface. And it's really important not to over submerge this Smart Shape Healers. So great product. I'm really excited to start restoring it. And I think it's going to be definitely the game changer in coming years, the way we restore these cases. In the past, we have done many encode cases, and that was also paradigm shift, the way we have done a digital implant dentistry. The one segment that we didn't like with the encode was particular design, which was very cylindrical. And this has prevented us to really develop the tissue and create the perfect crowns. And that has caused also a lot of, from our perspective, what we have seen remakes, because the restorative doctors will have really hard time inserting the crowns if we have anatomically designed them and the tissue is really tight in that process. So exciting product, very exciting for BioHorizon to see the conical connection and the Smart Shape Healers. So yes. So with the next upcoming segment, I will try to a little bit share my experience on a full arches. I know we have spent now over 30 minutes discussing the single units, which has been in United States historically the bulk of the business, but full arches in the last decade have tremendously picked up, and we have seen that amazing trend with it. So I'm gonna make a very short break until you get your question. So it's gonna take 20-30 seconds, and then we're gonna continue with our presentation. Okay. So the full arches, the way we started doing them, not many things have changed in a sequencing. So in a sequence for full arches, we have a 3 segments. One segment is a pre-planning. The second segment is the day of the surgery and immediate load, and the final segment is the final restoration. The acquisition of information has been also pretty much same for every protocol. So we have a patients who are partially edentulous. We use a teeth as a reference to merge the informations, and then we have a fully edentulous patients with a different workflow, such called dual skin workflow when we are doing a pre-planning stage. So in this process of the full arches, pretty much the clinicians provides to the laboratory intraoral scans or physical impressions together with the CVCT. On our side, we merge them together, and then from there we design the prosthesis based on incoming parameters, aesthetic, phonetic, and a function. We double check that everything has been correctly aligned, that between the designs and existing, and the same designs have been transferred into the CBCT informations. So this way we have a pre-op informations, we have a new anatomical design, and we have a bone informations. From there, in majority of our cases, or majority surgeons and periodontists, implantologists we work with, so we do guided surgery process. So we pre-plan the informations, we do a remote review session, they approve the plan, and from that approved plan, we generate drilling protocols, surgical reports, and a master list of the products needed for the day of the surgery. So a couple of years ago, we have implemented the Real Guide software, which was also a game changer for in-house production of the surgical guide, and has kind of like eliminated a lot of small softwares that we have used in the past to create the workflow. Now, finally, we have one in combination with Exocad or 3Shape that allows us to take these cases for in-house production from start to finish. So another great company that we utilize is a spotimplant.com. They use artificial intelligence. Sometimes in our full arch cases, we have implants that have been placed in the past that need to be utilized. So, and it's very difficult to discover their connections, their brands. So based on the PA or X-ray, you can submit this to spotimplant.com, and they will provide you the reports, which allow us to select the restorative parts if we decide to utilize them. And artificial intelligence has been in dentistry now for some time, and the process has been more and more intensified. And especially now that we see that some of the companies getting major investments, and the recent investment was also from ADA, American Dental Association. They have also invested in a company called Overjet. So it's going to be very interesting to see how artificial intelligence going to drive our treatment planning, case acceptance, and insurance-based patients in the future. So for fully edentulous patients, we use a such called a dual scan protocol. In this protocol, so you need to have a functional appliance that reassembles aesthetic, phonetic, and function. And then a clinician will perform a scan of the appliance in the mouth with the markers and appliance by itself. So this information pretty much provide us the bone position and correct prosthetic position. If the appliance is not of the good quality, if it's not correctly fitting, if it does not have a good positions of teeth, such a denture could be scanned with a particular protocol, could be submitted back to the laboratory, and then we can create a try-in appliance. In a case that patient does not have any denture, which is sometimes the case, or many cases that patient have lost the teeth and somebody has made a denture and it's ill-fitting denture and it's sitting somewhere at home and they are not using it. Now they're showing up for the treatment plan. In this protocol, the clinician will go through the conventional process of taking the impression, border molding, and then we create a prototypes. These are printed prototypes with a keystone printing material denture try-in, and in our operation, we use a SIGA printers. So very good workflow, great product. for the trying process. So sometimes the cases after planning could not be loaded, or there are high chances because of the bone density, particularly maxillary arch, that we will not achieve the primary stability. In that cases, we create a immediate dentures. So also several years ago, we have implemented a evotion system from Ivoclar, which is in a partnership with VHF. So another great product. So pretty much all our immediate dentures that we produced, they are milled in one piece with their shell technology. The great thing about that is that these blocks are fully cured, so there is no monomer residue, and it's a high density, very minimum, if any, porosity. So which is really great against the healing tissue. So just here, side notes for our final dentures, we do some final and removable work, final work for removable and for the dentures. So if we are making the final ones, then we prefer to use Evotion Dent, so which is a multicolored or multi-layered block in compared to Evotion one-piece block. They are monochromatic blocks. So, and we have tested and find out that our clinician and our, from the color matching standpoint, the key mill pink blocks, they work really nice. So what we do is we mill them in a two-piece. So we mill out of the key mill the base, and then we mill the teeth out of the Evotion Dent. And if you mill them on VHF machines, this is the experience you're gonna see if you can watch the video in the middle of the screen. So the milling quality is really amazing on it. And then the fit, it just fits like a glove. So this is immediately shortly after milling, with sprues being cut off and put in a place. So we do the same process with split file concept also for our flexibles. The material that we have selected to use in our operation is a company called TCS or TSC. So they have the material called iFlex. And that iFlex pretty much matches really nicely the color of the key mill, because sometimes we have combination cases, and it's also, as a flexible material, it's thermoplastic based. So if clinician feels that it needs to achieve a little bit more retention, it can easily heat the iFlex and get the better adaptation in a mouth. So this is just a summary of a dual scan protocol, the process of scanning and generating the informations. And pretty much this is what we are looking for. We're looking for correctly sitting the denture and very clear image of the bone, so we can correctly select the position of the implant's multi-unit abutments and correctly select the access holes. So this way the access holes don't end up in between the teeth, and they do not end up too close on a facial or way too palatal or lingual, which will make the prosthesis very bulky. And in my personal opinion, consider big failure of the final restoration. So on the day of the surgery, there is very three defined workflows. They have kind of like settled down now in the United States. One workflow is a stackable, in my personal opinion, the fastest workflow when the patient is in a chair. The second one is a photogrammetry. So we have embraced this workflow and start really liking it. And we have kind of mature with the process as we are selecting all the products into the sequence. And another great workflow is a grammetry from company that produces OptiSplint. So we do use them frequently with our clinicians who do not have a photogrammetry, or they are far away from our driving distance. So for the restorative stage. So, and I will just go very briefly over the workflow on the stackable guides. So as I mentioned, so we use a real guide for this process. And the process is the following. So you're gonna generate a foundational guide, then you will have a carrier. Carriers are used to position the foundational guide. The area where you secure the foundational guide, you have a plane, and that's gonna be your reduction plane. So from that reduction plane, you do the reduction. So you place your secondary guide, which has a sleeves, and you secure it with the pins. You place the implants, and then you put your immediate temporary restoration. So let's see how it looks on a live patient. So this is the day of the surgery. Surgeon has made the flap, has inserted the carrier together with the frame guide, has secured it in a place, so has removed the carrier, performed the extractions and a bone reduction. So the second step is a secondary guide with the sleeves, or with some systems, you can make it also sleeveless if that's the preference. So the guide is secured also with the clips. So it's nice and rigid during the whole process. Implants have in place, multi-unit abutments have been inserted, and temporary cylinders have been screwed into place. In a final stage, the immediate temporary restoration has been positioned and clipped in place, and then the sides have been picked up. Pretty much, it's a very straightforward, very predictable process. The only, if I can say, the primitive segment into it is the pickup process and adjustment process, but pretty much it doesn't have much downtime. I would say with way we designed this stackable PMMAs, it's like 5-10 minutes to a little bit polish it, adjust it, and get it ready for a final delivery. The informations as a two-set informations have been taken to the laboratory. One set gets delivered to the patient, the second set goes back to the laboratory. So if anything needs to be changed, informations are digitalized based on instructions. Once the implants are post-integrated, we produce a final try-in set. So, and on the first try-in set, the clinician inserts this fast or swift appliance in a patient's mouth, does the try-in, picks up the tissue, because these informations now have been matured, so the bone and tissue have settled down. We didn't have this information on the day of the surgery, so he just injects the low viscosity impression material underneath, and with all this checklist sends back the appliance to us to create a final input and second final try-in. And then from that final second try-in, he brings the patient for a second time, does very quick check on everything, make sure that patient is fully satisfied with the whole process. Again, goes through aesthetic, phonetic, functional parameters, details, and then these appliances are sent back to us to create a final bridges. Yeah, it is very predictable, straightforward process. Again, one tip for the communication with the clinicians. Many clinicians, they tend to write long prescriptions, and many times they just write them so quick that it's very difficult to read it. I think one of the best way to communicate the details between the laboratory and a clinician is like a short video. So especially if you have like a tricky cases, the patient can speak into it, you can hear the phonetics, you can see how the patient is dynamically, interactively utilizing the new appliance. And as a skilled designer, you can pick up small details and immediately correct it. So we do the same thing for our aesthetic cases. In this particular case, is a very young patient, conventional missing laterals. So, and this prosthodontist is just explaining us what needs to be corrected and the way we're going to proceed with the case. Yeah. So videos, I would say great. It's a fantastic tool for communication, especially on the details, and it will tremendously reduce the follow-up appointments or additional appointments for the try-in. So now photogrammetry, like I said, is becoming extremely popular. The price of the units is significantly sinking from the original range. So we are using for our operation micro mappers. So we do find them out to be very accurate, very light, and very fast and easy to use. And pretty much what photogrammetry does, it takes sets of the pictures that align the implants correctly. So, and that's pretty much what it does. It just takes the informations of the implants. And then in a laboratory, we use these informations to merge them together. So the workflow for photogrammetry in our perspective is, again, we do a certain level of pre-planning, and from pre-planning, we design a temporary restorations. At that time, we do not produce them. On the day of the surgery, the surgeon will perform certain level of marking. So they use a fiducial markers, or they can use the teeth, or you can use the combination of it. So, and with these markers, we merge the pre-op informations with the informations on the day of the surgery. And the scan is performed with capturing the implants with intraoral scanner. The tissue has been captured. Once these informations have been captured, they have been translated to us. Once they are translated to us, so what we do is we do the fine tuning of the intaglio surfaces, and then the appliances, they go into the printer. So we are using predominantly, again, also if we work in a field, Asiga printers. They have a multi-range of them in-house. We have these big heavy ones for the clinical portion. We use the smaller portable ones. And we print with the Titan, which is composite-based material. So it's very straightforward. After the printing, cleaning, curing, and processing. We do also find the Vita products, glaze products, the new generation, to be fantastic for glazing. I can highly recommend. And extremely important for any printing is a curing unit. So we are using Uvitron. Uvitron is the company out of the Boston, Massachusetts area. So if you consider, any other unit to be good, Uvitron would be like same like curing unit, only on steroids. It's extremely powerful and give us the results that we need. So because incorrectly cured printing material, they are going in a patient's mouth. They could be highly carcinogen. They can cause a cancer. Sorry for my pronunciation. So grammetry workflow today, I'm just going to discuss with you very briefly the restorative step. We predominantly use them in a combination with our clinicians who have intraoral scanner. So the process for it is, for example, if the clinician already has patients that have been loaded and wants to perform the corrections, so they can unscrew the appliances, put the reverse scan bodies into the appliance, scan the appliance. They can use their scan bodies, connect them with the flowable material, and then they scan the tissue. So once these informations are scanned, they are all merged together. And the great thing about this workflow, we can create a physical master model, which is not possible or in a workflow of the photogrammetry. So once these informations are transferred, pretty much is the very similar process of cleaning the tissue, trimming the tissue, performing the changes, and sending the appliances back for the try-in. And after the final try-in, we go into the final stage. So very quick summary on the sequence. The stackable guides, probably the most and fastest way to do it. Photogrammetry, probably the cleanest way to do it. And grammetry is probably the combination of these both worlds in a one. So all three processes have their applications. With photogrammetry becoming very trendy, and I see definitely more growth as the units they're getting into the $20,000 cost range. So very important segment. I just want to start going towards closing our presentation. So it's a zirconium. I cannot emphasize enough how important it is to do the correct selection of your blocks. Do not make a financial decision. Make a selective decision based on the quality of the product. This is a sample of the material that we are using in our operations. What we look here is from the lower portion to the upper portion is the strength towards the incisal edge, less strength. So we have a correct chroma, correct hue, and correct translucency. This piece that I was just holding against the light is approximately 1.5 millimeter strength. So in our operation, we use iodide, and recently we have also tested the Dental Direct product out of Germany, which is also another fantastic product, and we are looking more and more to utilize it in our operation. The reason we have liked the iodide is definitely because of their homogeneity, and the Tosso powder, Japanese powder, very famous for high quality product. If somebody asks me what is the 5 top products that I have bought in the last 30 years in our operation, that's the Gema ovens. especially astromat generation. So we also use them in a sintering or zirconia. That's extremely important, especially on a long span bridges, sleeveless bridges. So they are using silicium carbon elements, which they're extremely stable with the heat production. Finishing off our zirconia, we complete our cases with the GC initial product line. I have been using it also since 2003, 2004. I was a clinical instructor for them. And I do find out that my team gets much better results with this product line and more capabilities than with pre-mixed materials like Mayo or some other bottle-free products. So again, this is big discussion in our industry. Should we do sleeveless? Should we do final appliances with the sleeves? So over the years, we did find certain level of debonding in a tie basis just because zirconia is very difficult to bond. And a couple of years ago, especially in the last 12 months, we have shifted doing more sleeveless concept. And so far, knock on wood, we have really great results. For this process, we use two types of the screw, Rosen screw, the blue screw that you see on the left side, and again, desk screws. So desk screw has their generations 068, 069 screw. This is also now gold generation with, I think it's P10 screw. Again, desk, fantastic product. So Rosen screw, also excellent product. Again, we will see what the research and feedback gives us on a conical versus flat screwing into the chamber. So what will be the results on it? I'm really excited to see some of this research in the future. In a situation where there is a limitation, sometimes we have a way off angulated situation, then we will use just the sleeves. So the appliance will be sleeveless except that particular side. Again, we use it as sleeves for that situation. Another great product that we have implemented recently is a blender for dental I-bar module. Great product. So we mill every of our difficult cases, challenging cases, implants with the pterygoid implants, long span bridges. It is just secure. It gives you additional security that these bridges will not break. So the last product that we use as our final restoration for patients who have certain level of TMJ trauma, or they're looking for cost-effective solutions, or they do not like a clicking effect if you have double arch cases. So we have developed a protocol of milling fiber reinforced resin together with the evotion blocks, and then we fuse them together. So the fiber reinforced blocks, they have a same flexibility and same E module like a bone, which provides a tremendous amount of the absorption into the chewing system. I will highly recommend also to use this material. It's called Trilor. So in combination with the evotion blocks. For our all milling in a 5x range, pardon, we have selected R5 mill. It is a highly capable mill, and I can say without reservation now, using it for 2 years in our operation, we have a multiple R5 mills in a day-to-day operation. It is a ultimate digital implant dentistry machine. So with our mill, we mill a titanium. If needed, we mill chrome cobalt, PMMA, zirconia, you name it. This machine does repetitive, high quality milling. Besides that, it has that wet and dry capacity, which it is a fully automatic process. It has an open architecture. It can absorb different CAD softwares without the rejections. They're handing over the blocks through the chamber is exceptional through the direct disc technology. And the VHF has really good CAM software. So I have been in communication with them. They have been ongoing, coming with the new generations we are testing. And it's great to see fantastic manufacturing company who came out of hardware and invested tremendous amount of resources to produce the CAM software. And another great thing for all of us who are purchasing this equipment, it comes in a package, so there's no additional cost for the CAM software. So if somebody asks me my top 5 purchases in my career, besides my Dakemas, my NSKs, and like a reference suction, which I also love, it will be definitely R5 mil. So it's a fantastic product. So, and in kind of like a closing statement of this presentation, so what we have been challenged in our industry is that everybody provides to the dental laboratories, to technicians, and also to clinicians products. And then we have to work really hard selecting all these products into a workflow, functional workflow that we can repetitively create a successful stories. So it has taken me 30 years of validations, testing, working on a manufacturing site, being alpha and beta tester for many companies, that we have assembled what I feel now very comfortable, a procedure that we can repetitively restore the cases, prepare the cases, and restore the cases in aesthetic zone, and be very successful by creating not the crown's teeth, and also very successfully take a very comprehensive restorations in combinations with the implants and create beautiful results. And what we always see, it is these patients and the reason why we work so hard. And as you can see on this picture on the right side, this is a patient on the first day when the case was presented to her. And and you can see certain level of concern, anxiety, skepticism. And then you see the final outcome and final results, totally different patient. So they call this full arch dentistry, emotional dentistry, and it's really true. And it's really rewarding, and it's a whole purpose, professional purpose why we do this. So as you can see, this patient had a ill-fitting old partials that he has been wearing. And finally, he went to the clinician who suggested to him that there is some other solutions based on the implants. And this is one of the cases that we have also restored. So with my final closing statement, I do really apologize to extending this to 1 hour. I was planning originally 45 minutes, but I'm not native speaker. I'm not that fast speaker. I will always suggest to, when you do your all-on-X cases, is to make also night guards and provide them in a package, because you do all that beautiful work, you want to protect that work. And many of our patients, they are not aware that they are broxers and clinchers and grinders, especially in a society and time that we live. So we see that as a part of ongoing dental disorder. So my last segment would be here. If somebody asked me, besides my top 5, who would be my queen, who would be my king product in a digital implant dentistry, I would say a VHF definitely would be a king product that I will use and that we are using very successfully. And the queen product would be the Asiga printers. And it is even interesting for me and very exciting to me to see the further developments of this both technology as we are going into the next generation of the digital implant dentistry. On this note, I would like to thank you for taking the time, and I think now we're going to go through the questions.
Thank you so much, Amira. This was a great presentation, and it's fine that you went for the hour because you had such good, excellent, pertinent information for the customers. And I want to thank them all for being so interactive with us. Now, if you wouldn't mind, if you have any questions, you could type them in at the Q&A, but I can go over really quick what the results of our polls were. So it seems like 60% of our attendees are using the Desk Smart solutions. So I don't know if you have any comment on that, Amir.
I would just embrace the other 40% to go with the DES if they're not using authentic or they have a concern. I have used them over the years. They do very meticulous the diligence in the research and development of the products. They are excellent.
And our second one, if they're planning on milling in-house, and it seems that 75% are saying no, and 25% are saying yes, they plan on milling in-house. So what do you have to say about that one?
There's 2 segments there. One segment is with VHF mill and 4+ mill. So for approximately $30,000, which is justifiable investment if you see the trend of increasing implant cases. So I will suggest to buy that mill. And the second thing, which is really important there, they have their blanks, and DES has also put the regulatory package together, what I have understood from their presentations, which will allow the laboratories to be covered under manufacturing agreement, and the laboratories are going to be FDA compliant. So this is definitely the segment that will allow the laboratories to do in-house production, reduce the production time, reduce the operational costs, and increase the profitability.
And it seems like on the third question that all of our attendees are highly satisfied with the zirconia blanks that they're using. I'm not sure which materials, but they're happy with them, so that's a good thing. I guess that some good results.
That's great to hear. So I will definitely suggest, if you are not using, take a look into Dental Direct new material line. Has been carried also now by Zana. I was so glad to see that you guys picked them up and brought them to United States. Um, uh, I do a lot of milling in a 20 millimeter and 25 millimeter range, and you can see very quickly which company has neat product, because it's very difficult to get consistency in a sleeveless once you start milling in this higher range products.
They're really easy to deal with as well, Dental
Yeah,
Direct, and I will tell
yeah.
you, if anybody's going to Chicago, they are planning on launching some new zirconia, some
Yes.
really exciting new zirconia. So please join us in the Zon Ballroom in Chicago. You'll be happy that you did in order to see this. I believe we will be having some lectures with them as well. So that should be interesting and exciting. Also, we have a lot coming up in Chicago. So please take a look at, LMT's website, our website, to take a look at all of the exciting education. We're going to have a lot in our classroom, as well as hands-on demos, table clinics that are going to be running for 3 days straight. So we have a lot of new stuff, a lot of new manufacturers with us, a lot of different workflows. So it should be pretty interesting. I'm excited for Chicago this year. Amir, you're saying that maybe you might join us in Chicago.
I will do my best. So Chicago is not my favorite in February.
I
So
know.
and I'm definitely planning to be at the IDS. It's gonna be the 100 years, big celebration, big anniversary. So if time allows, I will definitely try to come to Chicago and spend some quality time with
Good. Zon
Rich
Ballroom
and the
ENF,
Zon
have
team.
some fun with us for
Sure,
sure.
looking forward to it. So.
Coming up in January, which will be hitting our website very, very shortly, we're going to have some great stuff with exocad. So the first will be on January 8th. It's a demonstration of exocad denture design with Dan Elshinger from exocad. He'll be joining us. And on January 15th, we have exocad versus 3Shape. Why can't both win? Dan Morano, CDT, will be joining us, and he's going to be explaining why he uses both in his laboratory. So I would love for all of you to join us then. Please go to zondental.com, go to the education tab, and register as soon as you can. We look forward to having you there. I just want to wish you, Amir, a very happy, healthy holiday season. Same to all of our attendees. And we just appreciate you all so much, and for you trusting us with your education throughout this whole year. And I look forward to a happy, healthy, very, very educational 2025 with all of you. So thank you so much.
Thank you, everyone.